Start.
Am I start? Okay. A very good afternoon to one and all. I'm Dr. Ruchika Ghosh, third year postgraduate student. Greetings and a warm welcome to the fourth session of the masterclass series on behalf of the Department of Conservative Dentistry and Endodontics, Bangalore Institute of Dental Sciences in association with AS Karnataka. Before we commence today's program, I would like to invoke the blessings of the Almighty to make it a grand success. Today, we have an eminent international speaker amongst us. Sir is going to enlighten us on the topic ultrasonics in endodontics. So without any delay, let's get the program started. I hereby request our mentor, our HOD, Dr. Ramya Raghu, to invite and address the speaker for the day. A humble request to all the participants to mute their audio and switch off the video during the session. Now, in the end of the session, we would be having an interactive question and answer round. So kindly forward us your questions in the chat box for the speakers to solve your queries. Thank you. Over to you, ma'am.
Thank you, Ruchika. Good afternoon, dear members of ACE Karnataka, faculty members and postgraduates. I welcome you all to the fourth program of this masterclass series on behalf of the chairman, Shri Katuri Subbarao, our directors, Dr. Swaira and Dr. Siri Krishna, our principal, Dr. Vinaya Espai, and the staff, Department of Conservative Dentistry and Endodontics at Bangalore Institute of Dental Sciences, Bangalore. Thank you all for your unstinting support for this masterclass series and your excellent response so far. This has kept our morale really high. And for today's program, we have a highly accomplished international speaker, someone who's already well known to us through IFIA 2020. He is Dr. Mustafa Anwar. He is the second speaker to grace our program from Egypt. Thank you, sir, for your magnanimity in readily accepting our invitation at such a short notice. He has been very much involved in our program today. Dr. Mustafa graduated from Ain Shams University, Egypt, and went on to obtain his master's degree in endodontics from the same university in 2015. He also earned a diploma in healthcare and hospital management from the American University, Cairo, and he is presently a PhD research scholar. He has served as faculty at British University, Egypt, and infection control officer at British Dental Hospital, Egypt. He has been an invited guest speaker at several international conferences and has conducted numerous hands-on programs. He is a proud member of Style Italiano. He's a silver member and a key opinion leader for endodontics. He has a specialist microendodontic practice at Cairo, Egypt. Now, today's topic is ultrasonics. Now, ultrasonics as such is not something new to endodontics. We can all recall the pioneering works of Martin and Cunningham way back in the 1980s when ultrasonics was introduced in the field of endodontics. Though it did not live up to its promise then, it has reinvented itself along with microscopes and has found a number of innovative applications in endodontics. Let us now listen to Dr. Mustafa as he explores the role of ultrasonics in modern endodontics. Over to you, sir.
Thank you so much, Dr. Ramya, for this kind edification and nice introduction. I'm really honored to be here today among you, Dr. Ramya, Dr. Ashish, and all the participants from India. It's really an honor and a pleasure to be here. And of course, it was an honor to be also in India, but virtually in the IFIA 2020. Hoping that this pandemic ends soon so I can visit India physically in the near future. I'm going to share my screen now. And if I may ask, it's already
Yes,
It's
clear?
fine. It's fine.
Clear.
Yes,
It's clear.
it's fine. Okay. Okay, and as Dr. Ramya mentioned already, that the ultrasonics, it's not new in endodontics, but as we all know, in the modern endodontics now, we can just modify or develop new techniques for using of ultrasonics as one of the most important instruments and tools in root canal treatment. I was very happy with these two designs. That's why I decided to share them in the start of my presentation. And I hope this lecture is going to be a fruitful and informational webinar for everyone. So let's start together. What are the ultrasonics in endodontics? And already, as mentioned by Dr. Ramia, it was already introduced by Richmond in 1957, and this is just history. And then by Martin and Cunningham in 1976, there was some development and some promotions to be done to these devices. As we all know, the ultrasound, it's the energy just produced with a frequency above the range of human hearing, which is 20 kilohertz. And now what we use in our ultrasonic machines, it's from 25 to 40 kilohertz, depending on the power mode which we are using, either for periodontics, for endodontics, for the gingival purpose. But now we are developing the ultrasonic handpieces, which can produce a range of 1 to 8 kilohertz, just to produce lower shear stresses and to reduce the risk of any cracks or any alterations on the tooth surface. The ultrasonic method that we use is magnetostrictive, which converts the electromagnetic energy into mechanical energy. And that's why we have to be careful during the heat production of this instrument. And that's why coolant is always requested or allowed to be used with the tips of ultrasonics, so we can decrease the amount of heat production in these instruments. So why we use ultrasonics already? It provides excellent visibility and selective cutting efficiency. And as we all can see here from the tips that I'm already showing you, if you can see these tips, it has a band here, and it's very thin. So it can give you a very good visibility and very good accessibility. And of course, if you have a very small tip like this one, you can just aim it to the area or to the work part that you need to operate on. So you are having a selective cutting efficiency. It's very smaller than conventional round burrs, and the material is quite different. It may be covered with abrasives to allow to remove more cutting efficiency and to allow to remove any dentine or calcification in a conservative way while exploring the canal orifices. So let's discuss what are the tips made of and what are the design features of these tips. So we have many aspects to tackle here, like if does it have an active tip or an inactive tip? This body of the instrument, does it have smooth surface or a milled surface? Is it diamond coated or not? Is it made of stainless steel or nickel titanium? And what is the connection type? So having an active tip or a smooth tip, the active tip, we always use it like an end cutting tool. So it will be used for removing of the fiber post or any obstacles present in the pulp chamber, or even for the broken files in the coronal third, in the middle third, or maybe in the apical third. And it's used mainly when we are trying to get a good view and to decrease the amount of iatrogenic errors during operation. If we have a smooth tip, which means it's a non-cutting tip, so all the action is done by the body of the instrument and not the tip of the instrument. And here it's like a bulk or vibratory instrument, which means that it's transmitting lots of vibrations and lots of energy to the a metal post. If you want to remove the metal post, so the action is not done by the tip, but it's done by the body of the instrument. And here are examples. This is an active tip, and as you can see, we are having a smooth body, but only pointed and sharp tip. So all the cutting is done by the active part here. While in the other one, while we are having the smooth tip, the tip here is rounded and it's very smooth, and there is no cutting at all done by this tip. All the action is done by the body of the instrument. This body can be diamond coated or non-diamond coated. And if it's diamond coated, it will be more we are having more abrasives and more cutting efficiency and more durability. But you have to be sure that when the tip is already diamond coated, it requires less time than the stainless steel or the zirconium nitride tips to cut similar preparations. But at the same time, you need to have irrigation all the time, because already the debris removed is going to stuck and to be sticky on the body of the instrument and decreasing its effect. So continuous irrigation is requested during the usage of these instruments. And here, as we can see, this is the diamond coated tips and this is the non-diamond coated ones. What about the smooth or milled? The body of the instrument can be already a very smooth and it's not going to do any cutting. So the only cutting which will be done will be at end cutting, only at the tip of the instrument. But if it's milled, it's going to give you an action of more cutting efficiency, but at the same time, more longevity than the abrasives one, because already the cutting is done into the tip itself, not adding abrasives on the like an add-on on the tip. As you can see here, this is the smooth one, and this is the milled tips. The material which are being made of is like stainless steel or nickel titanium. The nickel titanium tips are much more fragile than the stainless steel, and that's why the stainless steel is quite the main key player in most of our daily root canal treatment practice. And the nickel titanium, they work with a low intensity inside the canal, and also to be activated while you are inside the canal walls. Otherwise, these tips will fracture if they are being used outside. Here, as you can see, this is the stainless steel tips, different types, and this is the nickel titanium. The last but not the least, we are going to talk about the ultrasonic files, like the EndoChuck. Mainly, it's used for activation of irrigation. I'm going to show you the next slide first. This is the EndoChuck, as you can see, and we have a screw here, and you have the file. These endosonic files or the U files, you are just putting it inside the tip and screwing it for the EndoChuck. These K files can be used for activation of irrigation, to remove intracanal broken files, sometimes in the middle or apical third, also to put and position the MTA in the apical third of the canal. So they can be classified according to their use, either axis refinement tips, vibratory tips to transfer the frequency and the energy to the metal post, to the bulk removal tips, or troughing tips in searching of middle mesial canals, MB2 canals, or hidden canals, or removing calcification. So after we discussed the tips, we have to know what are the advantages of using these tips over burrs. As I mentioned before, it's for giving you more visibility and more vision, so you can proceed more with more cautious and less heterogenic errors, especially under dental operating microscope. Also, these tips is much smaller than the conventional burrs or tapered stones with rounded ends, so it's giving you more greater control and more accurate removal and more precise work part for removal of tooth structure. So we are achieving the concept of conservatism, which we are talking about in the last 7 or 8 years, which is minimally invasive endodontics and taking care of the tooth structure, not to remove virgin dentine, virgin enamel, to keep the tooth structure and to preserve the pericervical dentine, which are the 4 millimeter of tooth structure located above the crestal bone and 4 millimeter of tooth structure located below the crestal bone. Also, it can give you the cavitation effect within the irrigation during activation of irrigation, and which will be discussed later. So this slide is like, like I decided to put all the applications of ultrasonics in endodontics in this slide. So you can see that if you are going to use it in the pulp chamber only, you can use it either for the axis refinement, for finding hidden and calcified canals, for removal of any attached pulp stones. And then we can go for the coronal and middle third, where we can remove obstacles like metal posts, we can remove fiber posts, broken instruments located in the coronal or the middle third. We can remove gutta-perca during retreatment. We can use it for the activation of irrigation inside the root canal, also for placement of the MTA apically, and of course for the ultrasonic condensation of gutta-perca, although I believe it has a less rule in the application of condensation of gutta-perca during obturation. And of course, not to forget the application in the apical third, which is the surgical endodontics. But actually, this one needs a full lecture to discuss, so I'm not going to discuss it today. So these are my main ultrasonic tips. As you can see, I have the ED3D, the ED6, ED14, and ED60. So let's see what each instrument can be used. As you can see here, it's covered by abrasives, so it has a lateral cutting, has a tip or end cutting, so I can use it for access cavity refinement. I can use it for troughing for the hidden canals, to search for the middle mesial like in lower molars, or to search for the MB2 like in upper molars, and removal of pulp stones. The 86, it has a smooth body design, but it has a pointed sharp tip, so it has an active tip. I can use it for troughing of canals also, for hidden canals. And the good thing about this instrument, because it has a sharp pointed tip, is that when you go for searching of middle mesial or an extra canal, when you find the canal, the tip will suddenly drop inside the orifice. And at that time, you will stop doing any more troughing. And that's it. No more troughing, more exploration is needed. And if you can explore with your endoprobe, EG16, is there an orifice already for the MB2 or a middle mesial, you can go for the coronal flaring step. But the important thing is the drop that we can get already from the pointed tap here. Also, we can use it for the removal of broken files in the coronal or middle or apical thirds, or removing of the fillings or the cement around metal posts. And of course, we can use it also for the removal of the fiber post inside the root canal. Take care, sometimes you can use it for the passive ultrasonic irrigation, but it's very risky. ED14, it's used as the same as the ED6. It has the same design, but it's quite a bit larger in size. Okay, so we are going to use it only in the coronal and middle thirds, and mainly coronal third because of the design of the instruments. The ED60, it looks like a K file, if you can see, but these cutting edges, they are blunt. It's not cutting at all. And we use this tip only for activation of irrigation inside the root canal. One of the most important two tips that I like to use is the ED12D, and you shouldn't consider the name of the instrument except when you are using the same brand like woodpecker. But if you are using any other brand, you can use these tips mainly, which is like a round stone only. I use it for troughing of hidden canals and removal of pulp stones. And I believe this shape of the instrument helps me more than any other instrument, even more than the tapered stone with rounded end, which can be used also for troughing of hidden canals and removal of pulp stones, adding to that for the access cavity refinement, or even to transfer the energy, or acting as vibratory instrument to transfer to metal post in order to move it from the root canal. So I gave you an idea and theoretical explanation for the ultrasonics. I believe the lecture now is going to shift more into a clinical aspect, and I believe everyone likes to see how we can apply this clinically. As you can see here, I have a lower molar, and in this lower molar, I had already the isthmus between the two canals, the mesiobuccal and the mesiolingual, and we have to remove this isthmus. We have to remove it for two reasons. The main reason is in order to search for extra canals like the middle mesial canal, and the second reason is to remove all the bacterial infiltration inside this area and to remove the pulp tissue present already in this isthmus, because the bacterial load in this area is quite huge. So we have to remove it and then to clean it after that and to do more disinfection. So after troughing with ultrasonics, I found the middle mesial canal and then I did my obturation. But I have to show you one thing. When we talk about extra canals, one of the tests used to search for extra canals, I know it's not relevant to our topic today, but it's a very interesting video, so that's why. It's the red line test, especially when you are addressing a pulp tissue which is vital. So removing and doing the access cavity, removing the carious lesion, doing the access cavity, and then you can find, as you can see here, I can find the blood coming out from the MB2 canal. So this is called the red line test. Here is the mesiobuccal, distobuccal, and the MB2 canal, and the blood is coming out from the MB2 canal. And this is what we call the red line test. So what we will have to do is to remove the dentine shelf here over the MB2 canal using ultrasonics, and then to go for the shaping or mechanical preparation of the MB2 canal in upper molars. What about lower molars? Here is a lower molar, and here I was using the ED 12D tip, having a rounded abrasives tip of the instrument here, as you can see. And I decided to do troughing and to remove the isthmus between, to clean the isthmus between the mesiobuccal and the mesiolingual canals in the lower molar. And as you can see here, I did my troughing. More troughing and more removal of dentine in the isthmus. After removing the dentine in the isthmus, the dentine shelf, we can find that middle mesial canal is found already. So I will start my mechanical preparation for the middle mesial. And here, as you can see, the middle mesial canal, it was found, and it was joining with the mesiobuccal canal. Here in this case, it was referred to me to do root canal treatment for a lower premolar, but this premolar, lower first premolar, I believe, and this lower first premolar, it has a recently made crown, zirconia crown, or Emax. Actually, I do not remember. So I decided to do a very conservative access cavity, or what we call a ninja access cavity. So this ultra conservative access cavity, I just made a drop with my handpiece, and after that I shifted directly to the ultrasonics. And I decided to do flaring of the access cavity walls, and this is what we call access cavity refinement. So let's see. Here I'm doing the access cavity refinement and doing flaring for the canal walls. Just moving all around of the access cavity in order to get, as you can see here, in order to get the flared walls. So no need to increase the size of the access cavity itself, just to do more flaring of the access cavity walls and more access cavity refinement, so you can do your mechanical preparation safely. Here I had a lower second molar with C-shaped canals. I had to do troughing all around so I can get the extra canals, like these two canals. As you can see, I have 4 canals in this lower C-shaped second molar, and this is after obturation. I believe one of the most underrated and not addressed topics in endodontics is the orifice refinement. We all hear about access cavity refinement. We just modify the access cavity walls. We can get a straight line access cavity. We can remove calcifications. We can search for extra canals. But one of the most underrated topics in root canal treatment is the orifice refinement. Here in this upper second molar, I had a mesiobuccal orifice, a distobuccal one, and a palatal one. But actually, the mesiobuccal orifice, when I was trying to do shaping, I had the mesiobuccal orifice and then a separation into 2 orifices after that, a mesiobuccal and an MB2 canal. So I decided to do orifice refinement, which is already modifying or refinement of the orifice so as to enlarge its size, so I can go and get a straight line, not a straight line, but a nearly straight line axis to the mesiobuccal canal and to the MB2 canal, as you can see here. And here, if you were trying to do this with any hand piece, high speed or low speed, I believe perforation will be the end result. Don't try to touch the floor of the pulpal floor with any stone or bird in a high speed hand piece or low speed one. And here, as you can see, after finishing the orifice refinement, I can see the mesiobuccal and MB1 and MB2 orifices already present. So in such an area like the pulpal floor, never ever to try to use your high-speed handpiece or low-speed handpiece. In this case, in this upper right third molar, as you can see here, I had 4 canals. And for me, during my root canal practice, I always believe that taking a 3D or CBCT, cone beam CT X-ray before starting your root canal treatment in upper or lower third molars is very crucial and very important. Most of the cases I receive in my clinic is like, like it's like a bomb gift box. It's like a bomb wrapped in a gift wrapping. So you can see like it's quite nice from the outside, but from the inside, I don't know, because I am a referral doctor and a referral endodontist. Most of the cases coming to me is like disasters, and I have to deal with that each day. So it was referred to me to do a root canal treatment for the upper right third molar, and it was a strategic tooth to save. As you can see, the patient already has lots of premolars and molars already extracted in that side. So we decided to keep the tooth and to save it. I decided to take a cone beam CT, and I can see that it has 4 canals. So doing an access cavity in upper third molar, I will never go for a conservative access cavity or ultra conservative one or a modern access cavity design. I will just go for the traditional access cavity, and then to use the ultrasonics in order to do troughing and search for the MB2 canal, as you can see here. And what was quite interesting that the MB2 canal was located about 2.5 to 3 millimeter away from the mesiobuccal orifice. As you can see in the video here, I have the 4 canals, mesiobuccal, and the MB2 about 2.5 to 3 millimeter away from the mesiobuccal canal, the distal buccal orifice and the palatal orifice. So after getting the full information and all the details that you need to know before starting the case, I believe it will be an easy one. That's why I say that taking a cone beam CT X-ray, it's like you have treated the patient without meeting the patient yet. You have done your everything in treating the patient, but you didn't even greet the patient in your clinic. One of the applications also for ultrasonics is the removal of the metal posts. And as you can see here, when we are trying to remove a metal post from inside the root canal, what we do is transferring the energy and the frequency already in the mechanical energy already present here in the ultrasonic tip into the post, the metal post. So this energy and this frequency will cause the post to start de-cementing from the cement around it, and to be a little bit loosened and start to dance while removing it. That's why we have to use the tip of the ultrasonic in a counterclockwise. like in unscrewing motion. So you are using the tip in counterclockwise all over the head of the metal post until the post starts to dance. Here, as you can see, I'm trying to remove the metal post, moving in a counterclockwise motion. So you will see that the post starts to dance. Don't rush. Keep more moving in a counterclockwise. And here actually I is moving the post and at the same time the gataperka around the post. In this case, I will show you more applications like removing of the post, removing of the filling or the cement material around the post, and then removing of the cement which is already closing the apex and causing an obstacle, closing the orifice and causing an obstacle to the initiation of the root canal treatment of after removing of the post. Because here we have three problems: the post, the metal post itself, the cement around the post, and already this post was drilled in a wrong direction inside the root canal. So the cement was covering the main orifice of the canal. So we have to remove the post, the cement around the post, and the cement already closing the orifice of the canal. As you can see, post removal, the cement, I am trying to remove the cement first around the post. After removing of the cement, I will shift to removing of the post. Now I'm just moving in a counterclockwise, as you can see here. And when you see that the post starts to dance, please don't rush. Keep moving in a counterclockwise. We have to be sure that the post is very loose before starting to remove it. We don't want the post to be broken. We don't want to do any stresses over the root canal dentine, which may cause any iatrogenic error. So here you can see that there is more dancing of the post. After being very loose, I started to use the needle holder in order to remove the post, as you can see. Now, this is the wrong pathway of the canal, and this is the main pathway of the canal. So I started to remove the cement, closing the orifice of the main pathway of the canal. After removing of the filling material, and now I gained my drop, as you can see. I got my drop. This is already a patent canal, so I can start to do my retreatment and removal of the gataperca from inside the root canal very easily. From the another applications of ultrasonics is the activation of irrigation. And the ultrasonics has very two nice effects and helpful effects for activation of irrigation. The first thing is the cavitation, which is the formation of thousands of tiny bubbles, okay? And these bubbles rapidly implode. And implode, it means to the inside, not like explosion to the outside. So having a high pressure and more implosion, it will produce a shock wave due to the pressure inside and to remove the biofilm. And this shock wave will go to the lateral canals inside the tunnel tubules and all to the lateral anatomy and all the root canal spaces inside the root canal system. The second thing is the acoustic streaming, which is the production of shear stresses and shear forces helping to remove all the debris from inside the root canal to the outside coronally, so that we don't have any debris inside the root canal, and more cleaning and more disinfection. Also, the activation of irrigation helped us to decrease the disinfection time, because as we all know from literature that the root canal irrigant must be in contact with the root canal dentine for at least 20 minutes in order to achieve good disinfection. But with activation of irrigation, we know that the international standard now, or the golden standard activation time, is 3 cycles, each cycle of 30 seconds activation of 20 seconds activation of irrigation, either sonic or ultrasonic, and that's it. And not to forget that we have one EDTA, 1 minute of EDTA activation using sonic or ultrasonic inside the root canal also. So during the activation of irrigation, what we do only is we just place our ultrasonic tip, either the endosonic file, or if you are using another tips like the K15 or K20 from Satellite, whatever what you have, you just place it passively inside the root canal. You don't touch any of the root canal dentine at all. So that's why it's called passive ultrasonic irrigation. And here you can see the acoustic streaming with the cavitation effect done inside the root canal. Here, all these bubbles, I'm just positioning my ultrasonic tip inside the root canal passively. I'm not touching any of the walls. Just for about 20 to 25 seconds, and I have done my activation of irrigation. I'm going to repeat this cycle to activate the sodium hypochlorite inside the root canal for about 3 cycles. I also using another technique. I call it SIA technique, SIA, simultaneous irrigation and activation technique. Here, as you said before, as you saw before in the last video, I already placed my irrigant inside the root canal. I did my activation after that. But here, I'm going to show you the difference between placing the irrigant inside the root canal and doing activation of irrigation, or to place continuously the irrigant during the activation process already. Sometimes we have already ultrasonic equipments or devices which have a container. This container, I can place the sodium hypochlorite irrigation inside it. So I'm going to use it as a coolant. So I'm going here to refresh continuously my irrigant during my activation. So that's why it's called the SIA technique, simultaneous irrigation and activation. Here, I place the irrigant inside and I'm doing activation. So as you can see, the irrigant is inside and only activation is done. The instrument is placed passively. But you will see here that I'm going to show you that I'm going to use a fresh irrigant all the time of the activation procedure time. Like for the next 20 seconds, the irrigant will be coming from the tip already, and I will be doing simultaneous irrigation and activation at the same time. So no need to refresh or to change the irrigant or sodium hypochlorite every cycle, as you can see here. So more irrigation, more activation. As you can see here. So we save time by doing simultaneous irrigation and activation. And as you can see already, the push of the irrigant coming will help more to produce more and more actions of the ultrasonic. Here in this case, I'm showing you that there was a loop between the two canals. As you can see here, the mesiobuccal and the mesiolingual canal in the lower molar, there is a loop filled with the resin sealer. I was using resin sealer at that time. And as you can see already, this space, you can never reach it with manual files. You cannot reach it with rotary files. But the only thing to reach is your irrigant. So that's why you have to pay attention to the disinfection step inside the root canal. And this is a lateral canal also filled with my sealer. In that case, I was doing a retreatment for a lower right first molar, and I have a very big lesion, as you can see here, and that was a sinus tract gataperca tracing. I removed the gataperca from inside the root canal. I got my middle mesial canal, as you can see here, 3 canals in the mesial roots. I had already an extruded gataperca before. I didn't try to remove it. I just stopped at the working length. I didn't try to remove the already extruded gataperca in order not to cause any injury, especially I didn't get a lesion already. I don't have a lesion already beyond the distal root. And now, after doing my disinfection and activation of irrigation, as you can see in the post-operative X-ray, I got a lateral canal beautifully filled with my bioceramic sealer. One of the most underrated topics in endodontics is the Krell technique. What is the Krell technique? Krell technique is when you have a broken file inside or a silver. Actually, it was introduced first for the silver points, but now I'm going to discuss it about the broken files inside the root canal. Let me explain it to you over this case. In this case, I had already a broken instrument in the lingual canal in this lower first premolar. This lower first premolar, it had 2 roots, okay, and 2 canals. 2 separate roots in the last 4 or 5 millimeters, starting from the middle third. This broken file, I decided to remove it by using the technique which is called Krell technique. It was introduced in the 70s or 80s. This technique depends on bypassing already the broken instrument. As you can see here, I did my bypass using manual files, and then this manual file, I just attached my ultrasonic tip to this ultrasonic to this. Let me say it, rephrase it again. I did my bypass already to the broken instrument at the last 2 millimeter, and then this already K file, which already done the bypassing step, I attached the ultrasonic and touched it from the top. So the ultrasonic energy is transferred from this file to the broken fragment already. So it will help to cause more vibrations and more energy transmitted to the broken instrument at the last 2 or 3 millimeter indirectly. So I'm doing indirect transmission of the ultrasonic energy. The ultrasonic tip is attached or touching the file here. The file transmits the energy to the broken instrument at the last 2 or 3 millimeter, and then the instrument can be removed easily. But be sure to do already bypassing of the instrument before. As you can see here, the broken instrument was about 2 millimeter in long, and here I was tackling and doing my shaping procedure. I finished, and after finishing the shaping procedure and disinfection and obturation, you can see that I got already a lateral canal, as you can see here, filled with my bioceramic sealer. So this is the Krell technique. As I already discussed with you, it is already in the 70s or 80s, and as you can see, and it was already introduced in order to remove the silver points from inside the root canal. But we are using it now to remove the broken instruments indirectly. And as you can see here, this is the ultrasonic tip. Okay. By the way, this tip can be used, the one which can be used for scaling or any other tip, because the idea is to transmit only the ultrasonic energy to this file, which will be transmitting it indirectly to the broken instrument inside the root canal. Here I had a broken file which was located in the coronal and middle third, and I used the ultrasonic to remove it very easily, and it was a straight canal. And after that, I am going to show you, here I had remnants of gataperca at the root canal dentine walls, as you can see here. During root canal retreatment and gataperca removal, always pay attention to remove all the gataperca, because this gataperca can have already bacterial load located below them. So we have to remove all the bacteria in order to get clean and disinfected the internal and opened the internal tubules. So I always take an X-ray after removal of gutta perca and after complete disinfection to be sure that all the remnants of gutta perca is already removed. As you can see here, I still have remnants. After disinfection, there is no remnants of gutta perca on the root canal dentine, my master cone, and the obturation X-ray. That was a series of retreatment for upper lateral and canine anterior teeth and first and second premolars. I removed the posts. I removed the gutta perca. This is the upper lateral incisor. This is the upper canine. That was a custom-made post. I removed it the same way as I showed you. And this is the first premolar and the second premolar. I removed the gutta perca. I removed the post. I removed the fillings inside the root canal. I did my shaping step. This is my master cone X-ray, and this is the post-operative X-ray, as you can see, for the upper lateral incisor after the post and core restoration. Sometimes, in most of the cases, in 80 or 90%, sometimes I do the coronal restoration, because as we already know that the coronal seal or the lack of the coronal seal is one of the most common causes for the root canal failure. So we have to pay attention to the coronal seal. That's why I do the coronal seal immediately after finishing my root canal treatment. Here in this case, after searching for the MB2, you can see in this upper molar that the master cone is already showing the confluence of the two canals, the mesiobuccal and the MB2 canal, which was already confirmed by the application of bioceramic sealer in the MB2 canal, and you can see the bioceramic sealer is getting out of the mesiobuccal canal. Here, this case would revert to me to do retreatment. As you can see, the previous doctor, he managed to remove the gutta perca in the coronal 1/3 of these tooth, but he told me that I couldn't manage this one. What I found here was just a yellowish, a white material. I don't know actually what is this white material, but it was very hard one. So I decided to remove this white material using ultrasonics. And I started digging using my ultrasonics and already removing only the white color during my retreatment procedure under dental operating microscope. So under microscope, I can see the white material all the way around. I decided all the way around to go with my ultrasonic tips. And as you can see here, I removed all the white material. Here is my master cone, and this is the post-operative X-ray. And of course, here I did continuous wave of obturation technique, continuous wave of compaction in order to fill 3D the root canal. And as you can see, this morphology cannot be filled except by continuous wave of compaction technique, which is still now considered the golden standard technique. This is quite an interesting case for upper right lateral. I had gutta perca here in order to do to remove. I removed it, but I had remnants of gutta perca in the apical third. I decided to remove it, and actually the last 2 millimeters of gutta perca I cannot remove at all. I decided to use H file in order to remove, although I don't prefer H file to remove the gutta perca. I use the K files only due to the high separation of the incidence of H files. That's why I don't use it frequently. But actually, the last 1 or 2 millimeters of gutta perca is still present. So I decided to shift the case into an open apex case. I got my ultrasonic tips directly straight. It was a straight canal, directly straight to the last 2 millimeters. And I managed to remove the gutta perca, as you can see here. But the case was an open apex case. I damaged the apical foramen, I know. But I decided to place MTA in the last 4 millimeters to do apexification. And here is the MTA placement in the last 4 millimeters, as you can see, and this is the post-operative X-ray after doing the 3D obturation in the coronal 2/3. Here in this case, I'm going to show you an access cavity refinement. This is upper right second molar. The patient was very irritating patient. He was moving his head a lot. This video is in a high speed, fast forward motion. I had a very constricted access cavity. The pulpal floor was already constricting the distobuccal canal, the mesiobuccal, these two buccal and palatal canals after access cavity refinement. I didn't remove the soffit, as you can see here. And then I started to remove and to do the corona flaring after removing the pulpal floor and doing the access cavity, the pulpal roof, and doing access cavity refinement. And as you can see already, corona flaring is one of the most important steps, so you can reduce the stresses that will be encountered on the files later during your glide path or shaping step. I started to go for the glide path step for all the canals, for the mesiobuccal and for the distobuccal and for the palatal canals. The patient had a limited mouth opening. That's why you can see me struggling while shooting the video. After that, I shifted to the shaping step. What I'm going to show you now that after the ultrasonic and ultrasonic access cavity refinement and the shaping, this is how it looks after shaping. These are some cases, and this is the importance of activation of irrigation. As you can see here, lateral canal beautifully filled. Here I was using the bioceramic sealer. This is upper right third molar, and as you can see, I had 4 canals. The MB2 canal was already present, and this is the post-operative X-ray. I had a C-shaped lower second molar, so in order to tackle and to disinfect all these root canal spaces, you cannot do that using rotary files or manual files or anything. What is available only will be the irrigant material, and the disinfection step will be the main part and main player in this such a case. Here in this case, I have lateral canal already beautifully filled, as you can see. I had here a molarized upper left first premolar having 3 roots, and I used the ultrasonic to do the orifice refinement, which was already discussed before, because as you can see here, the buccal and the palatal roots were sharing the same foramen. So I decided to do orifice refinement, same orifice. So I decided to do orifice refinement in order to widen a little bit the orifice, so I can get a nearly straight line access to the buccal root and a nearly straight line access to the distobuccal root. Here is an S-shaped canals. This is the lower right third molar. Actually, I did some orifice refinement to the mesial root orifices in order to gain a little bit straight line access here. Here I had a broken file inside the distal root. I removed the broken file using ultrasonics, and here I had 3 canals, including the middle distal canal in the distal root, and this is after obturation and removal of the broken instrument. Here we have dancing roots for upper left first premolar, S-shaped curvatures with a very thin root. And in such cases, you have to decrease the size of preparation. And actually, I ended my shaping here up to 25 taper 4%, and I couldn't increase it much more because I have a very thin root, and I was afraid to go for any transportation or to cause any fracture for the used file. and I will mainly depend on the activation of irrigation using ultrasonic or sonic. In such case, I decided to use the sonic activation using the endo activator from Densify, because it's plastic tip, so it can reach up to that area safely. Having an extra distal lingual root in lower left first molar. Another case, shaped roots as we mentioned before. Sorry, this is just, oh, sorry, I'm repeating the cases, sorry. Here in this case, in this accessory root, I had a broken instrument. I removed it using the CRAL technique, and this is a file which I used to bypass, and then I attached my ultrasonic to indirectly transmit the ultrasonic energy to this broken instrument through this bypassed file. And as you can see, this is the net result, and this is a post-operative X-ray having four separate canals and 3 separate roots. Remember this case, I showed you this case before. It was a retreatment case and having a very J-shaped large lesion, and this is after 7 months of follow-up, as you can see here. I have good tissue repair, I have a nice healing and good formation of bone in the furcation area and in the periapical area related to the mesial root. So all the steps we are doing in root canal treatment, we only aim for getting the healing, and this is our reward in root canal treatment. This case, I had a follow-up of 4 months. As you can see, there was a huge lesion. This is after 4 months, and this is after 1 year follow-up. Thank you so much. I really appreciated your listening, and I was very happy to be with you today. And this is my contact email and mobile number. This is my Facebook profile and Facebook page. This is my Instagram account, and this is my YouTube channel, Dr. Anwar-Endodontics. I'm really honored to be with you today. Thank you so much.
Thank you so much, sir. Sir, can you may now start sharing your screen, sir. Sir. So thank you so much, sir. It was a very nice and informative presentation from your end. So we would like to give you an e-certificate as a certificate of appreciation. So kindly
Thank you
accept
so
it,
much.
sir. Yeah.
Thank
Thank
you
you,
so much.
sir.
I really appreciate it. It's my
Yes.
pleasure.
The
My pleasure to be with you
certificate.
today already.
Thank you, sir. The certificate will be mailed to your email address, sir. Thank you
Thank you
so
so
much.
much.
Now we have the question and answer round. So over
Okay.
to the session's moderator, Dr. Ashish Shetty, sir, and you, Mustafa, sir. Over to you, sir.
Thank you.
Yeah, Dr. Mustafa, yeah, that was a very nice presentation. Thank you. Thank you so much for taking your time and coming here. So we have a couple of questions. The first one, when you do your indirect ultrasonic activation, especially with the broken instrument, which is towards the apex, near the apex 1/3, is there a chance of it extruding beyond while doing the, after you bypass and you activate it indirectly? Is there a chance of a risk of the instrument going beyond the apex? Is the question.
It's a very good question, by the way. That's why I said we already do bypass, because already when I have my instrument already bypassed the broken instrument already, so I'm closing the space epically, and then I indirectly activate the instrument. So when I do activation, the file which is already bypassing. Can I share my presentation again?
Yeah, sure,
Okay,
sure.
yeah. Okay. To show you one thing. Is it shared now?
Yes.
Okay. As we can see here, the broken instrument is located in the apical third. The same scenario and the same question as you already, sir, asked. I did my bypass already, and now I placed already. When the cave file has already bypassed the broken instrument, it's closing the apex already. So this broken instrument, when it's already indirectly activated by the ultrasonic, there is no chance it's going down, it's going up. This is the first thing. The second thing, I have done already coronal two-third flaring above the instrument. So the space is already located above and not beyond.
Okay. Okay. So
I hope
the next question. Yeah. So how do you, sorry, one sec, just. Yeah. So you, in one of your slides, you mentioned about using sonic and ultrasonic instruments. So they like to know, like, in which one to use in which condition, the sonic and ultrasonic.
Actually, when I have an S-shaped canals or double curvatures or having a severely curved canals, the ultrasonic tip can be only located at the straight part of the canal, which is the coronal third. And you cannot place it beyond the curvatures. Okay? So in order not to cause any ledges, or in order not to break the ultrasonic activation tip itself, so I decide to shift directly to the sonic activation using endoactivator, EQS by MetaBioMed, whatever the device. But to use plastic instrument for the sonic activation, this will be much more safer. 3 years ago or 4 years ago, I was doing a mix between both. Sometimes I was using the ultrasonic activation in the coronal third or in the straight part of the canal, and shifting to sonic in the apical part of the canal or the curved part of the canal in order to be safe. And I believe mixing of sonic and ultrasonic will be much more beneficial if you have used the sonic in the curved part and the ultrasonic in the straight part only.
Okay.
In order to avoid ledges, broken tips of ultrasonics, and everything, and any ethogenic error.
Yeah. One more question. So you do you use ultrasonic to remove GP during retreatment? And if you're using, which tip do you recommend?
Okay. Actually, I use the rotary files. I don't use ultrasonics to remove the gutta-perca, but I use ultrasonics to remove the remnants of gutta-perca during the disinfection step, because the remnants of gutta-perca cannot be removed. You know, like sometimes when you remove the gutta-perca from the canal, you still have on the root canal dentine all over the wall. You have remnants of gutta-perca. In order to remove this gutta-perca, you should shift into using the ultrasonics in order to tackle and transmit the vibrations to the remnants of gutta-perca, to the remnants of the sealer on the root canal dentine, so it can be removed. So during the disinfection step, during the activation, I remove the remnants of gutta-perca, but I'm not using the ultrasonics to remove the gutta-perca starting from the very start, like rotary instruments, like hand files, like gutta-perca solvents. No. Some clinicians prefer to soften the gutta-perca in the coronal 1/3 using ultrasonics, but I don't do that. I use the system B instead. It's much more easier and much more safer.
Okay.
Ma'am, do you have any questions?
Yeah. Dr. Mustafa, I think you need to switch on your video.
I close it. Sorry.
Camera.
Yeah,
Is it on?
thank you so
Sorry.
much. Thank you so much, Dr. Mustafa. That was like a splendid presentation about the non-surgical use of ultrasonics in endodontics. And like you said, surgical ultrasonics is something, totally, it's a totally huge chapter, a huge topic, and there's so much to talk about use of ultrasonics in surgical procedures. But you have highlighted almost every aspect of ultrasonics for non-surgical endodontics. And I'm glad you spoke about the Krell technique, which, we have also tried in our early days as postgraduates, we have tried it and it has been successful. Thank you for reviving that technique again. I'm sure most of the PGs will, take this tip and try to use it, because it's a very simple procedure without even any ultrasonic device. With just our scalers, we can try to do this, provided we bypass
Exactly.
the instrument properly. Thank you. It was simply marvelous. I'm, astounded by the kind of clinical cases that you have shown, and very grateful to you for sharing it with us. It's been a real pleasure to have you on our program today. Thank you so much.
Thank you so
I
much.
hope to have
I'm really
many more
honored.
collaborations with you in the future.
Yeah, for sure. Yeah. I'm here whenever needed. I'm here whenever needed. And thank you so much for your kind words. I'm speechless. I don't know what to say. I'm really happy and really honored to be with you today and sharing this clinical experience. And we are just learning from each other, everyone. So thank you so much. I really appreciate my presence there in BIDS. And I hope for more cooperation in the near future. And I hope I was giving a more fruitful and informational lecture like today. Thank you so much.
Hoping to see you in IFIA 2021.
I hope so. I hope so. I hope so.
Yeah.
Thank you.
So thank you, Dr. Mustafa. And I must mention, I think we've been trying to reach each other over the past 2 weeks. And because of the time difference, Dr. Mustafa always left a message back. And that's very kind and considerate of you. And we really appreciate you coming on board for this webinar in our times of need. So thank you so much. And we're very extremely grateful to you so much.
Thank you.
It's my pleasure. And it's
So
an
with
honor
this,
anytime.
we come to the end of the session. We have some more questions which we will mail you. I think there are a few more questions coming in. We will personally mail you those questions and we'll pick up the answers. I think we would like to end the session. For those of you, our next session is on Saturday, and we will be dropping the poster, Sumit, and it'll be on 2 different topics, on lasers in endodontics and the elusive MB2 canal. So this is on Saturday at 11 o'clock and 12 o'clock. And with that, we will conclude today's session. And thank you, Dr. Mustafa. Thank you so much for everything.
So much.
Thank you.
If I may ask, how many participants were today?
We had 94 on the WebEx, and on the on the YouTube we had almost 60. So I think that's almost.
So that would be groups. Basically, there would be groups of people watching. So even though it is as one, because many colleges, they are doing, they are watching together. So
okay.
Totally, we had around 202 registrations.
Very good. Very nice.
And I think everybody was glued on to their screens when your session was going on. It was amazing. It's really, I hope they derive a lot of inspiration from your cases and the way you have handled them so beautifully. Thank you once again, sir.
My pleasure. Thank you so much. I really appreciate it. Thank you so much.